Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Pleasure to be back. I do have to say I have served on an advisory board for Gilead Sciences. We're going to talk today about hypertension, but we planned the timing of this poorly, I suppose. At the end of August and early September, the American Heart Association and ACC, American College of Cardiology, as well as probably several other hypertension societies, will be issuing new guidelines for the US. And if you're interested, there's a link to register for a webinar that will kind of summarize some of those new changes. But that said, I don't think it's going to be a lot of new groundbreaking changes, but we'll see. I will kind of focus on the 2017 guidelines, and like I said, I think that they'll serve you well. Some of these highlights that have been kind of put out there as new highlights are that the blood pressure thresholds for diagnosis and treatment of high blood pressure may or may not change. It seems like maybe they might change them for different age groups. Cardiovascular and cognitive risks of uncontrolled high blood pressure will be a focus, and then the act of calculating a cardiovascular disease risk using a calculator such as PREVENT or the older pooled cohort equations in order to risk stratify people and then tailor your approach based on that. And then to utilize as much as possible medication classes in fixed dose combination pills to improve adherence. All right, so with that disclaimer, those disclaimers, we'll start with some epidemiology of cardiovascular disease and HIV. You may have seen this slide before, I've presented it before, but just to point out that the risk of myocardial infarction, stroke, and heart failure are all higher in people with HIV compared to people without HIV. Over the years, this has been shown to be even greater for women. So the HIV-specific risk, even if risk overall is lower for women, the HIV attributable risk is greater for women than for men. But this is also an extremely important slide because at the end of the day, the factors that are driving risk in people with HIV are the same as the general population. And in this analysis of NA Accord, it's really total cholesterol, hypertension, and smoking at a population level that matters most for myocardial infarction. This would generally be true for other cardiovascular diseases as well. Of course, those with low CD4 count or elevated viral load are at increased risk, but because those risk factors are less and less common nowadays, we, on a population level, don't see that as much. But inflammation and immune activation certainly contribute, and they may contribute to the risk of hypertension. As you can see in this review from research last year, there are a potential number of relatively unique mechanisms in people with HIV that can contribute to hypertension. But I think that, like most people, it's genetics, lifestyle. Regardless of the cause, once we identify high blood pressure in people with HIV, it's really important for us to actually pay attention to it. And we have advocated for this kind of approach that it's time to extend the HIV treatment cascade because we get so many people to viral suppression that last 95, we need to then focus on prevention of non-AIDS comorbidities by appropriately diagnosing, managing, prescribing, and then having patients take their meds and adjusting medications and lifestyle therapies to reach blood pressure and cholesterol goals. But I think that there are unique barriers in HIV clinics. I've shown this slide also for a number of years. And this is what people would come to me and say when I started my HIV cardiology clinic in Cleveland. They said, I'd always thought I'd die of AIDS, so I didn't really think about stopping smoking. It wasn't important to me. There is this kind of misperception of risk, I'll say. And in this analysis from Alison Webble in the School of Nursing, comparing calculated ASCVD risk score with perceived susceptibility to cardiovascular disease, there's really very poor correlation amongst our patients. But there are other barriers as well. And one of them is this idea of who actually is responsible for doing primary prevention of cardiovascular disease in people with HIV. Now here on the West Coast, it's a lot different than where I was in Cleveland or at Duke. This is Lance Okeke from Duke, who published this analysis of data from Duke, showing that for hypertension, infectious disease, he was prescribing meds about a quarter of the time. primary care, about 17%, other people like cardiologists, et cetera, 20%, and 34% of people with hypertension weren't prescribed anything. So they, at least in their health system, noted that they weren't doing a great job. But Lance went on to further look at whether blood pressure control depended on who was managing the blood pressure. And if infectious disease was managing your blood pressure, you found about a 16% lower chance of control after adjusting for the confounders that they had in their data set, obviously at high risk of some residual confounding. But he uses that as a point to advocate for improved knowledge, awareness, and attention to hypertension. Now, in this analysis of the VA, they actually found the opposite. So they had compared consolidated care, which is where you go to your HIV doc for all your primary care, versus shared care where you have a primary care doc and an HIV doc. And they found that consolidated care actually was the majority of patients were in that sort of a model, 80%. And of them, 65% compared to 59% had controlled blood pressure. So they were doing better in that sort of model. So obviously lots of factors at play, but interesting nonetheless. So we designed a nurse-led strategy to try to improve blood pressure and cholesterol in people with HIV. And this was when I was in Cleveland at university hospitals, Cleveland Medical Center, Metro Health across the way in Cleveland, and at Duke. And you can see the full results if you want, that QR code. But here are the main results. And we saw about a 4.2 millimeter reduction in systolic blood pressure and a 17 milligram per deciliter reduction in non-HDL cholesterol, with essentially a 4-component intervention where the nurse was inserted into the care team to help kind of manage communication, to work with patients with their blood pressure monitor at home, to get blood pressure information from home and get it to docs to make decisions about what to do, and kind of overcome that clinical inertia that might otherwise exist. And you might not think a 4 millimeter mercury reduction is that much, but actually that would, in meta-analyses, would be associated with around 14% reduction in ASCVD risk events. So significant. Let's talk a little bit about diagnosis of hypertension, which is basically the same as in the general population. From the 2018 guidelines, that's when the new 140/90 became 130/80. And in general, I think that has kind of been taken up into clinical practice, although some people still think of the older guidelines, especially in older individuals. I just have a few pearls here. Obviously, the American Heart Association has tons of materials that are super helpful for a clinic that wants to improve how they're doing with blood pressure. But I think it's really important that you think about your clinic and how is the workflow for that clinic designed in a way that encourages accurate blood pressure measurement. For example, do you have the option of doing automatic blood pressures in a room where the MA may even leave the room and allow that patient to be alone to get a truly accurate office measure? At the end of the day, though, home blood pressures are really more important than office measurements. So don't totally disrupt your clinic workflow only for that reason. Automatic oscillometric blood pressure machines are more accurate than manual machines. That has been shown in recent years, so just keep that in mind. American Heart Association has a lot of helpful materials like this poster, as I mentioned, which just reminds everyone how to prepare for blood pressure measurement. And then another key pearl that I'd like to really highlight is learn how to enter home blood pressure data into your electronic medical record. We can do that in Seattle at the UW Medicine in our Epic. I'm sure other EHRs have ways of doing that as well. And as I've said several times now, home blood pressure is really the key. So to make a diagnosis of high blood pressure, really you want to get data from home. And on average, it's going to be about 5 millimeters of mercury less than office measured blood pressure. But for some people, it's a lot less. And for some people who have masked hypertension, they actually have a higher home blood pressure than they have in the office. The home blood pressure monitor shown here is an Omron device, which is a validated device. If you want to know if a device is validated, go to validatebp.org and you can check. That's really important. They've actually done the studies to make sure that they're accurate. And then some people get confused between home blood pressure monitoring, HBPM, and ambulatory blood pressure monitoring, which is sometimes difficult to get reimbursed. It typically is reimbursed for for the diagnosis of white coat hypertension. So if you have someone who has high blood pressures at home, but maybe doesn't have LVH or echo or on ECG, then you can do an ambulatory blood pressure for 24 hours where you're taking measurements every 15 minutes or so. It's kind of a complicated device, although they've gotten easier to wear over the years. And that gives you a truly accurate sense of what their blood pressure is at home. Secondary causes of hypertension is something everyone always wants to know about. This is from the general population. I'll just say that we don't really have data in people with HIV specifically, but keep in mind that secondary causes are really obstructive sleep apnea, renovascular disease, and primary aldosteronism. Those are the three key ones. Pheochromocytoma, not so much. But that kind of falls into this bucket with Cushing's, etc. And like I said, there really are no good data on secondary causes in people with HIV. So let's just talk for a brief moment about treatment. So this is the algorithm from the 2018 guidelines. Again, caveat, this may change, though I don't know that it will change that much. So I think it will still generally apply. So if someone has an elevated BP, the recommendation is not to start drugs right away. It's to recommend non-pharmacologic therapy, diet, lifestyle, reduction in alcohol use, etc., and then to reassess. Whereas if you have a blood pressure over 130 and certainly over 140, to consider therapy, particularly if someone is at higher ASCVD risk. And I think this is going to be really highlighted in the new guidelines because the number needed to treat will definitely depend on the baseline absolute risk of your patient, right? So in someone who's higher risk, the benefit of the medication is going to be greater. In extra CVD, we had an algorithm that we used that we recommended for providers to kind of get them off of beta blockers and onto more evidence-based drugs. We started with a combination ACE diuretic, and this algorithm was kind of borrowed from the Kaiser Permanente experience. And you can see, adding calcium channel blockers as needed, and then definitely MRA, a mineralocorticoid receptor antagonist like spironolactone or eplerenone, if GFR is acceptable and potassium is acceptable. That can really get someone with quote-unquote resistant hypertension, well, resistant hypertension being defined as being on 3 drugs and still hypertensive, that can really be effective. And if not, beta blockers really are kind of that final phase of your algorithm. And this is a study done by Matt Feinstein and his group at Northwestern looking at outcomes in people who are initiating any pharmacologic therapy for hypertension across the years from 2000 to 2018. And you can see that they found actually an increased risk of incident CVD in their cohort for beta blocker use versus initially starting on an ACE or an ARB. Whereas, calcium channel blockers and thiazides were kind of similar. But they did kind of suggest that ACEs and ARBs might have a decreased risk of incident heart failure, even if you included those with or without baseline CKD. So that's the take-home message. Beta blockers are not good to start with, but you may need them eventually, just not to start. And then, of course, we have to acknowledge the role of modern ART and treatment-emergent blood pressure on integrase inhibitor regimens. These data from ADVANCE would suggest certainly that there is a blood pressure effect, but interesting that the differences between regimens were significantly attenuated after adjusting for changes in BMI. And again, this was in South Africa, so a lot of the females actually in this study as well. So my approach to this is that ART may raise blood pressure. That may be true, but at the end of the day, it's very modest, and the difference between regimens are really extremely modest and should not be informing our choice of ART in general. Hypertension, I think, rarely merits a switch in ART. There are, however, important drug interactions to be aware of. From the Liverpool site, you can see this is just what it says about cobicistat and amlodipine. I have found in clinical practice definitely a lot more bad lower extremity edema in some patients who were on boosted regimens, especially if they get titrated to 10 of amlodipine. So my personal experience is that try to stick to 5 as the highest dose in someone who has a boosted regimen. So in conclusion, together with smoking and dyslipidemia, hypertension is a significant driver of cardiovascular risk in people with HIV. There are unique barriers to hypertension diagnosis and management in U.S. HIV clinics, but I think we can address those. Blood pressure self-monitoring at home is effective, but I think underutilized for many reasons, and we can discuss that if you want. Not least of which in Washington State is that Washington State Medicaid does not reimburse for a blood pressure monitor. The American Heart Association has excellent resources for hypertension management, so please check them out if you're interested and be on the lookout for the new guidelines. And I will end there.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.